Hello, we will be presenting on postoperative delirium in the geriatric population.
The outline for our presentation is as follows. Case summary, definition of postoperative delirium, pathophysiology of delirium, common causes, risk factors, clinical presentation, signs and symptoms, diagnosis, anesthesia considerations and treatment, and current research.
So our case summary involved an 81-year-old woman who underwent laparoscopic colon surgery under general anesthesia for sigmoid diverticulitis complicated by sigmoidovaginal fistula, and the patient had been treated for several episodes of polymicrobial UTIs with antibiotics before admission. She presented with delirium on post-op day 4. So her medical history included current smoker with 2 packs per day for 45 years, hypertension, and peripheral vascular disease with bare metal stents in her bilateral iliac arteries and left femoral artery. Her home medications included clopidogrel, simvastatin, bromazepam, valsartan, and bisoprolol, and all meds were continued until the day of surgery, except valsartan, which was DC'd 2 days prior to surgery. So her labs, electrolytes were normal, troponin was less than 0.04, her hemoglobin was 12.9, platelet count was 260, her ECG showed regular sinus rhythm, and her echo was negative for ischemia, but did show left ventricular diastolic dysfunction with hypertrophy. So induction of anesthesia was accomplished using propofol, sufentanil, and atracurium. Maintenance was done with desflurane with a mixture of 50% oxygen and 50% nitrous. The surgery duration was 3 hours long, and the patient was reversed with neostigmine and atropine at the end of the case. The patient was able to be extubated and then was transferred to PACU and then subsequently discharged to the surgical ward. Her post-op analgesia medications included IV acetaminophen, nefopam, morphine in the PACU, and then a PCA with morphine during the first 48 hours after surgery. So on post-op day 4, the patient presented with several episodes of confusion, disorientation, and logorrhea. Her GCS was 15. Her temperature was 37.2 degrees Celsius, but she had had a previous spike in her temperature the day before to 38.4 degrees Celsius. She had slight tenderness in her abdomen, and a CT scan revealed a 3-centimeter fluid collection at the anastomosis site. The most likely explanation for the postoperative delirium was related to the postoperative peritonitis from the anastomosis leak, which has been associated with precipitating delirium. Sepsis-induced delirium was also a factor in this patient's episode of delirium due to the peritonitis. It is thought that sepsis alters the blood-brain barrier via the production of pro-inflammatory cytokines. This results in endothelial adhesion and subsequent damage. The etiology of sepsis-induced delirium may also be in part to increases in O2 requirements or hypoxia from a systemic infection. So the patient ended up receiving antibiotics and underwent an exploratory laparotomy, which showed peritonitis from the anastomosis leak. She required mechanical ventilation, continuous sedation with midazolam and fentanyl IV, and inotropic support for 8 days in the ICU. After extubation, she did experience a second episode of delirium with disorganized thinking, inattention, and olfactory hallucinations. She had no fever, her labs were all normal, and the CT scan was normal as well. So the probable cause of the second delirium was related to withdrawal syndrome from her receiving IV midazolam and fentanyl for 8 days in the post-op period. Nicotine withdrawal was also considered and has been reported as a possible cause of delirium in ICU patients. So the treatment that they did for her second episode of delirium included a nicotine patch, but it did not reverse the delirium. Bromazepam PO was then given, with the delirium resolved within 2 hours after administration. The patient was discharged home 8 days later and remains well at 1-year checkup.
Postoperative delirium is the most common postoperative complication in older adults, affecting 5 to 50% of older patients after an operation. Postoperative delirium is defined as an acute alteration of consciousness and attention that is linked to an underlying physiological process. It is often described as a relationship between physiologic stressor and predisposing patient risk factors. 2 forms of postoperative delirium have been identified: hyperactive and hypoactive. Hyperactive is common in patients experiencing intense postoperative pain, such as a full bladder. Hypoactive is the most common type of delirium in the geriatric population and is caused by a variety of disorders.
The etiology of delirium is often multifactorial and difficult to diagnose. Interactions between patient risk factors, medical illness, and therapy can produce a complex neuropsychiatric syndrome. Drugs are implicated as one of the most common causes of post-op delirium and one of the most treatable. Elderly hospitalized patients are at high risk for delirium due to interactions between polypharmacy, altered pharmacodynamics and pharmacokinetics of drugs with aging, and their underlying pathophysiology. CNS active drugs are often used during the perioperative period, especially during anesthesia, and are most often implicated for the cause of post-op delirium. Alcohol and drug withdrawal during the perioperative period may also be a cause of acute delirium and should always be ruled out. The neurochemical basis of delirium is most often explained by a deficit in cholinergic transmission. Acetylcholine plays an important role in attention, consciousness, and memory. This theory is supported by the observations that anticholinergic intoxication produces a delirium that can be reversed by cholinesterase inhibitors and by the tendency of antimuscarinic drugs to induce delirium. However, cholinesterase inhibitors do not typically prevent or treat post-op delirium, so the pathophysiology is clearly more complicated. Alterations in neurotransmission involving GABA, glutamate, and the monoamines, serotonin, norepinephrine, and dopamine, have been linked to pathophysiology of delirium. Sedatives and hypnotics, such as volatile anesthetics, propofol, and benzodiazepines, potentiate GABA-mediated transmission, and at least one of these medications are almost always given during anesthesia for surgery, putting patients at risk for postoperative delirium. An excess of dopamine has been linked to hyperactive delirium, which responds to the dopamine receptor antagonist haloperidol. The dopamine theory is also supported by cases of delirium that are induced by antiparkinsonian drugs such as levodopa and relieved by dopamine antagonists. Both increased and decreased serotonin has been associated with delirium, and excess norepinephrine has also been associated with hyperactive delirium. Another proposed theory for the mechanism of postoperative delirium is an increased secretion of cerebral cytokines during physically stressful events such as surgery or illness. These cytokines may have an effect on neurotransmission activity within the brain. Thus, increased cytokines and altered neurotransmission may have a complex interaction that results in postoperative delirium. After cardiac surgery, there appears to be a component of brain injury as evidenced by changes in serum levels of S100 beta protein and neuron-specific enolase. This mechanism could possibly explain why patients undergoing cardiac surgery are at a higher risk for the development of post-op delirium. Increases in S100 beta protein have also been observed after abdominal surgery and appears to be related to the development of post-op delirium. So this diagram shows the different factors that play into the pathophysiology of delirium and links them together. As you can see, hypoxemia and metabolic derangements, along with drugs and systemic inflammation, all contribute and interact in a complex fashion. All the factors end up meeting at the endpoint of neurotransmitter imbalance and disruption of synaptic communication, which is thought to be the key theory behind the cause of postoperative delirium. So this picture illustrates how systemic inflammation in the body from such things as stress from surgery or infection may possibly affect the brain, resulting in postoperative delirium. The blood-brain barrier can become weakened from older age, inflammation, or exposure to drugs such as anesthetics and anticholinergics. This may possibly explain why postoperative delirium is more likely to occur in the elderly after a major surgery or stress to the body, as their blood-brain barrier becomes weakened and allows inflammatory mediators to cross. So the inflammatory mediators released into the bloodstream as a byproduct of the systemic inflammation cross over this weakened blood-brain barrier and result in activation of microglial cells, releasing inflammatory mediators within the cerebral tissue. This neuroinflammation then results in neuronal dysfunction, which is thought to contribute to delirium as well as postoperative cognitive dysfunction. Neuroinflammation has also been linked to neuronal death, which may contribute to the development of both postoperative cognitive dysfunction and possibly dementia.
The aging brain has decreased quantitative and qualitative functioning and decreased neuronal circuitry. This may account for the increased incidence of delirium in the elderly population. Causes can be pre-existing, as in the patient arrives to the OR already hypoxic or in severe pain. We will talk more about these risk factors in the next slide. Causes also occur as a result of surgery or anesthesia. This can include pain-induced delirium caused by unrecognized urinary retention. This is common due to increased residual bladder volume after anesthesia. Of course, anesthesia itself is a major contributing factor of delirium. Some anesthesia-related causes include benzodiazepine administration, ketamine administration, poor airway management, intraoperative hypotension, inadequate fluid replacement, and failure to treat hypoglycemia in the diabetic patients. Residual neuromuscular blockade is also a major contributor, as it can lead to hypoxemia, which is a known cause of hypoactive delirium in the PACU. Here we see the different neurotransmitter imbalances that have been associated with postoperative delirium. Notice that the only transmitter with decreased activity is the cholinergic neurotransmitter acetylcholine. Risk factors for postoperative delirium are plentiful and need to be assessed in the preoperative setting. Risk factors include age greater than 65 years old, cognitive impairment, severe illness or comorbidities, hearing or vision impairment, inadequately controlled pain, hypoxia or hypercarbia, dehydration, electrolyte abnormalities, especially hyper or hyponatremia, polypharmacy, and use of psychotropic medications. The risk factors that are in bold are those that have been outlined by the National Institute for Health and Care Excellence. These 5 risk factors have been labeled the 5 primary risk factors and should be assessed prior to any surgery. In this case, the patient presented with confusion, logorrhea, which is defined as excessive and often incoherent talkativeness, and disorientation. To the right, you can see the key clinical features of delirium. In the postoperative setting, the features that are important to observe for are acute onset, agitation, alteration in consciousness, and a fluctuating course. As you can imagine, these signs may be very difficult to identify in the PACU. Many patients are hypoactive after surgery as it is, but prolonged lethargy should alert the anesthesia provider that an assessment for delirium may be indicated. Here you can see the numerous symptoms associated with postoperative delirium. These symptoms can occur within a few hours postoperatively and progress for several days. Hypoactive delirium is associated with prolonged drowsiness after anesthesia and is difficult to diagnose. It is important to know when the last doses of medications were given and when these medications should be metabolized and excreted. This can help you rule out whether this is a residual medication problem or a physiologic process that is causing the drowsiness. Postoperative delirium can occur immediately after surgery or, as we see in this case study, several days postoperatively. It will always present with an acute onset. This should not be confused with postoperative cognitive dysfunction, which is a gradual decline of cognitive function and lasts longer than 2 weeks to several months. The CRNA should be aware of each patient's delirium risk factors, and they should be documented. The hallmark sign is acute cognitive change from baseline, so obviously the CRNA needs to be aware of the baseline neurostatus prior to administering an anesthetic. The patient's baseline cognitive function and neurologic status should also be assessed in pre-op and documented. In the PACU, the CRNA needs to be aware of the signs and symptoms of delirium. Diagnosis should be made after reviewing the history, labs, and medical records, and performing a physical exam. The CRNA should always be thinking of pain and hypoxia and the elderly patient as potential causes. Some delirium assessment tools include the Diagnostic and Statistical Manual of Mental Disorders, the International Statistical Classification of Diseases, and the Confusion Assessment Method Diagnostic Algorithm. There are no current recommendations for delirium screening in the at-risk inpatient populations. However, many facilities perform daily assessments. For ambulatory surgery, family or caregivers should be instructed to bring the patient to the ED if they notice excessive drowsiness or acute mental status changes. This is an example of an algorithm that walks providers through the assessment process and identifies delirium risk factors. It also walks providers through identification of organic and inorganic causes of delirium and provides the proper course of action, whether that be an ICU admission or treating the organic cause, such as pain or hypoxemia. In regards to anesthesia concerns, there are a few that stand out. Deeper levels of anesthesia have been shown to increase the incidence of postoperative delirium. Some studies recommend the use of BIS monitoring to monitor for awareness while keeping the anesthetic as light as possible. Certain medications have also been associated with increased occurrence of delirium, including anticholinergics, sedative hypnotics, especially ketamine, and meperidine. Benadryl and benzodiazepines have also been associated with delirium, though Benadryl is not as conclusive and results can vary between studies. Patients on chronic benzodiazepines may require benzodiazepine administration in the OR, or withdrawal may occur postoperatively. In regards to this case report, they concluded that the patient's delirium was not related to the anesthetic she received. Her first incidence occurred due to an anastomotic leak and peritonitis, and her second occurrence of delirium was due to benzodiazepine withdrawal, which occurred due to discontinuation of a Versed drip after 8 days in the ICU. When treating postoperative delirium, the anesthesia provider should first ensure adequate pain control, especially if the patient is hyperactive. Narcotics may be necessary, but should not be used exclusively. A multimodal approach should be considered, such as acetaminophen or ketorolac. Ensuring adequate neuromuscular blocker reversal is always essential and should be performed to ensure adequate postoperative ventilation in these patients. If residual neuromuscular blockade is suspected, Zigamidex may be considered. In patients that are not ventilating adequately, airway supportive measures may be indicated, such as oral or nasal airways, and perhaps even the addition of CPAP or BiPAP. Ketamine and preoperative Versed have both been associated with postoperative delirium, so other agents should be utilized if possible. When administering drugs in the geriatric population, the rule is start with low doses and titrate to effect. In agitated patients, low-dose haloperidol or a dexmedetomidine infusion may be indicated. Again, start with a low dose and titrate up as needed. Using antipsychotic medications should only be considered after non-pharmacologic methods have been exhausted and the patient is a risk to themselves or others.
Most of the treatment for postoperative delirium lies in its prevention. It is imperative to identify geriatric patients who are at risk for the development of post-op delirium. Efforts should then be made to reduce any modifiable risk factors. Patients should have continued interventions during the postoperative period aimed at reducing the occurrence of post-op delirium. If post-op delirium does develop, most of the treatment is supportive in nature. A team approach for the management of delirium is best, involving physicians, nurses, and family members in the care of the patient. Every part of the team is critical in not only resolving the symptoms of post-op delirium, but for prevention as well. Avoid drugs that have CNS effects if possible. These include anticholinergics, H2 blockers, benzodiazepines, opioids, and antipsychotic medications. Maintain adequate ventilation and oxygenation while ensuring cerebral perfusion to reduce metabolic stress on the body and neurologic system. Correct electrolytes and acid-base balance as needed, avoiding metabolic derangements. Utilize techniques to maximize the patient's awareness of their environment and orientation. These include providing an easily visible clock and current date, having lights on during the day, involving staff and family, and frequent reorientation of the patient. Low-dose haloperidol in doses of 1 to 5 milligrams can be used for symptom control as it acts as a central dopamine receptor antagonist. Physostigmine, used in doses of 0.5 to 2 milligrams IV, can be given if anticholinergic-induced delirium is suspected. Current research on the prevention of post-op delirium was conducted via a study across 2 surgical wards of a general hospital. A prevalence phase over a 6-month period was done where no interventions were carried out and the number of patients who developed post-op delirium were counted. After that, a 10-month intervention phase was carried out with a control group and intervention group. In the intervention group, a specially trained nurse in the management of post-op delirium performed interventions that are component measures of the Hospital Elder Life Program, or HELP. These interventions included validation techniques, improvement of sleep, cognitive activation, early mobilization, improved sensory stimulation, and improved nutritional and fluid status. The results of this study support the use of a specially trained nurse to screen patients at risk for delirium and train other nursing staff in delirium prophylaxis methods that could substantially reduce the incidence of post-op delirium in the elderly. The incidence of post-op delirium in this study showed the prevalence phase had an incidence of 20.2%. During the intervention phase, the control group had an incidence of 20.8%, which was very comparative to the prevalence phase of 20.2%. However, in the intervention group, the incidence of post-op delirium was only 4.9%, showing that the interventions had a significant difference in the occurrence of post-op delirium. This table shows the specific interventions that were utilized during the study within the intervention group to prevent the occurrence of postoperative delirium. Some of the interventions used included early mobilization, such as walking and taking meals at the table, improving sensory stimulation by ensuring patients had their glasses or hearing aids available and allowing personal items, improving sleep habits by taking into account the patient's own sleep habits and changing structure of the day if necessary, engaging the patients in cognitive activation through the use of reorientation aids such as a calendar or clock, group social meetings, and memory training. And finally, various validation techniques such as avoiding room changes and enabling distractions and entertainment were used. All of these techniques are patient-centered and focused on the prevention of postoperative delirium and should be used in current practice.
This concludes our presentation, and thank you for listening.